Welcome to Mercy Medical Center's live webinar. I'm Lynn Dennis, Program Coordinator, and today's topic is prematurity awareness, babies born too soon. Joining us today is Linda Klein, Director of Birthplace, Mercy Neonatal Intensive Care Unit and Pediatrics, and Brenda Enfield, Registered Nurse and International Board Certified Lactation Consultant at Mercy's NICU. After their discussion, they'll take questions from our audience. Now, if you are a regular attendee of Mercy's webinars, you may have noticed the format of our webinars has changed slightly. The method to submit your questions has also changed. Just hover your mouse over the green bar at the top center of your screen and then click on the question and answer icon at the far right of the script. From the drop-down box, select Host and type in your questions, and your questions will be confidential. Well, I'm very happy to welcome both of you to our webinar. We're going to begin with Linda, so I'll turn the mic over now to you so we can get started.
Thank you, Lynn, and thank you for joining us today and listening in on our topic. So we're talking about premature birth today, and some of the things that we're going to cover are the risk factors that are associated with preterm delivery, some preventive measures that you could do to prevent having a preterm delivery, and we'll also discuss some of the short-term and long-term complications that can happen when a baby is born before he's ready to be born. So as an overview, newborns are classified as premature when they're born prior to 37 weeks gestation. It can happen for a number of different reasons, and lots of babies who are born early may not necessarily need specialized care. It just depends on how many weeks a baby is born early. But one of the most important and effective things in preventing premature birth is awareness. Nearly 1 in every 8 babies in the United States is born early, and prenatal care, getting prenatal care, is a good preventive measure to keep that from happening. So there are risk factors that are associated with preterm delivery. Often if a woman has had a previous premature birth, she is at risk for having a premature birth with her future pregnancies as well. And that can be as early as 32 weeks of gestational age. Also, if the mother is pregnant with twins, triplets, or multiples, there is also a risk of premature birth because the uterus is enlarging at a quicker rate. And any pre-existing problems with the uterus, the cervix, or the placenta can cause premature labor. Most women that do have a different shape or a problem with their uterus or cervix do know that ahead of time. And then if the placenta is causing a problem, that is discovered during the pregnancy. And some women do have an unusual shape of the uterus. The most common shape that's unusual is called a bicornate uterus, and there are women that will go into preterm labor when they have that shape. Other risk factors, if a woman conceives with in vitro fertilization, she's also at risk for preterm labor, and some infections, especially in the amniotic fluid. Generally what happens, we think, with an infection is if there's an infection in the amniotic fluid, then the body kicks in and says, okay, this isn't a safe environment anymore, and the baby needs to come out. So it will cause a woman to go into labor early. And chronic conditions such as high blood pressure or diabetes can cause preterm labor, as well as a history of miscarriages or abortions. There are other factors that can be controlled. Some of the previous factors are things that are more inherited, but some of the things that can be controlled are using different substances like cigarettes, alcohol, or illicit drugs can all cause premature labor. So of course those are all contraindicated during pregnancy. Poor nutrition or not gaining enough weight during pregnancy can cause preterm labor, as well as being either underweight or overweight. There is some things in the literature now that being exposed to certain pollutants can cause premature labor as well. And these are other factors associated with premature or preterm delivery that a woman can control. If there is less than 6 months between pregnancies, it can cause preterm labor. Very stressful life events, such as the death of a loved one or domestic violence. We'll frequently see women who are in a car accident and come in, and we always monitor them for quite some time just to make sure that the car accident itself hasn't triggered labor. Any physical injury or trauma would come in that category. And of course, working long hours or having to stand a lot can stimulate preterm labor as well. If women have that happening to them, often they'll be put on bed rest until they get closer to term. We also know that there are certain groups of women that are at higher risk for preterm labor than others. African American women are at risk, and even though they do have term births, African American women are about 50% more likely to experience a preterm birth than women of other races, and we don't really know why that is true. Also, women under 17 or over 35, women who are not married, and women with lower levels of income and education are at higher risk than other groups. However, it should be said that women who do everything right during their pregnancies still can go into preterm labor and deliver without any known risk factors. And the opposite is true as well. Just because a woman has a risk factor, such as diabetes or high blood pressure, she doesn't necessarily mean that she will have a preterm birth. So prevention is really important, and like we said, there are a number of things that women can do to prevent going into preterm labor. If you are a smoker, it's important to quit smoking, avoid alcohol and illicit drugs during your pregnancy, and be sure to get early prenatal care. We do know that prenatal care is a good way to prevent this from happening. It's important to get prenatal care as soon as you think you might be pregnant, and be sure to keep all of your prenatal appointments during your pregnancy. If you're concerned about any of the conditions that you may have, such as diabetes or high blood pressure, be sure and have a conversation with your health care provider and keep a healthy diet. Take prenatal vitamins as well as your folic acid every day, both before and during your pregnancy. I'm going to hand the slides over to Brenda, and she's going to talk a little bit about babies that are born early.
Okay, I'm going to ask, first of all, is to forgive me. I've got a little bit of a cold, so I sound a little snuffly, so please forgive me for that. And if I start coughing, just kind of close your ears. First of all, the slide's a little fuzzy, but it kind of gives us a general idea of why it is so important not to have an induction before 39 weeks. Just the difference, 4 to 6 weeks can make in the growth of the baby's brain really makes a difference. They're not supposed to be out yet. They're supposed to be inside, snuggled against mama's uterus, and just growing like they're supposed to without all the extraneous sounds and noises and everything else going on. So when they are born early, we only, don't have the full growth there. And as it says, a 35-week brain only weighs 2/3 of what its total weight would be at 39 to 40 weeks, and that's huge. So Mercy is associated with the March of Dimes, and we have a protocol in place that we try not to induce women before 39 weeks unless there is a medical need, and that would be either for mom, baby, or both, just so that we can get that optimum brain growth for them. And March of Dimes has partnered with Mercy and has given us a lot of really cool information and stuff to help us along with this adventure. All right, going into some of the physical short-term complications. Most people understand that a preemie baby is going to have problems with breathing because lung is one of the main things. So a few of the things that we do to help support the baby is the very minimalistic is having actually a nasal cannula, which you've seen the adults walking around with the tubes in their nose and carrying their oxygen. It's pretty much the same thing the baby would have except on a much smaller scale. The next step up would be hood oxygen, which basically looks like a space bubble that the baby actually lies underneath, and the air around it is oxygenated, and we can control that so that we're not stressing the baby out with anything on their nose, and they can breathe in the surrounding air that we can adjust to for that. The next step down the list would be nasopharyngeal CPAP, and CPAP stands for continuous positive airway pressure, and the best way to describe that is if you think about blowing up a brand new balloon, it's really, really stiff and hard to blow up the first time. You let all the air out, then you go to blow it up again, it's much easier. That's because there's residual air in that balloon that allows it to expand again faster. That's what CPAP basically does for the baby, is it keeps a continual flow of air into the baby's lungs to help keep those lungs inflated so the little air sacs or little air balloons in the base of the lungs don't have to collapse down on themselves, and then the baby has to work so hard to open them back up again. And then we can do the CPAP by an endotracheal tube, which is a tube that goes down the baby's throat. That can be used mostly for mechanical ventilation where the machine breathes for the baby, but in this case the baby is breathing on its own. And then obviously the worst case scenario would be the mechanical ventilation. And most of the time these babies are going to be on them for a short while unless they are born extremely premature. Heart problems. Most people don't think a whole lot about that, but one of the problems we see with some of these babies is that they want to stay in the same pattern of circulation as they were inside mom, which means that the blood pretty much bypasses the lungs. Well, that's not a good thing. So the main cause of that is a little vessel called a ductus arteriosus. When that does not close, then we have what's called a patent ductus arteriosus, or a PDA. And that can cause the baby to stay in what we in the medical field call fetal circulation, which poses quite a few problems. It can close on its own over time. Sometimes they do need to be medically closed or, worst case scenario, surgically closed. Brain problems. Well, obviously these little people are not supposed to be outside of their mommies yet. So they're supposed to only be hearing muted sounds and muted lights. And then all of a sudden they're in the big wide world and there's lights all over the place and noise and all this other stuff that is totally overwhelming to them. So we try to do as much as we can in the NICU to mimic the intrauterine environment, and we do that with positioning and with soft lighting and decreased noise, which we call our minimum stimulation protocol. And what this means is that we're going to talk softly, we're going to be very gentle when we move the baby, not do anything fast. Make sure that any visitors that come in, the voice is going to be soft, so that we really do a lot to try to make the baby's brain develop as much as it would inside mom. We do have special cribs for these babies that go from a radiant heater down into an isolette so that we have ready access to these babies, and they can stay in there for a few days up to several weeks. Part of what goes along with our minimal stim protocol is actually watching the behavior cues of the baby. That's what tells us if the baby's stressed or if the baby's ready to interact with caregivers. And this is known as behavioral organization, and this is the baby's ability to maintain a balance among its subsystems like breathing, heart rate, color, all that, oxygen, while having to deal with, the lights, the sounds, and all that other stuff that goes on in a NICU. And these are reinforced by those of us who give care by recognizing and responding to these infants' cues. The first ones I'm going to talk about is the avoidance behaviors, and these are the times when we actually kind of put the baby in timeout, which is not as bad as it sounds. It just means that we stop doing stuff that is making the baby irritable or having complications. And some of those cues that we see are spitting up that's not associated with feeding times. The baby may gag frequently, get the hiccups, which babies get the hiccups, but sometimes these are more insistent. May have frequent bowel movements, do a lot of facial grimacing, may back arch away from the person around them or try to get away from the noise. They will actually do a finger splay or like high Hitler sign where they actually can either just put the stop sign up above their face or actually extend their little arm out. They can actually start waving their arms, look like a little airplane, do excessive sneezing and yawning, coughing. Gaze aversion is a really big one where they will not hold your gaze, they will look away from you. Or the other extreme is where they cannot take their eyes off of you. You have to break away from it. They get that wide-eyed, scared look like, oh my God, I can't get away from this. Those are the times where we would back off and allow the baby the time to get himself settled and get back into a state where they're comfortable before we would start doing anything. Then we would slowly reintroduce whatever it was that we were doing. Now the approach behaviors, that's where the infant is actually showing signs that they are ready to interact with people. And that can be tongue extension, looking like maybe they're looking for food, hands on face, making some cooing sounds, clasping their hands, grabbing their foot, actually putting their feet in a cross position where they look like they're just really relaxed, holding your finger, inviting body movements, putting their hand to mouth, grasping, making an ooh face, and yes, little babies can mimic an ooh face, and actually locking and holding a gaze without looking like they're getting too overstimulated. And then going along with that is we do a lot when they're able to go into, like I said, positioning, using firm touch instead of stroking. When baby's able to have mom and or dad come in and do kangaroo care where we hold the baby skin to skin against mom or dad's chest with a light blanket, which helps with their oxygenation level, with their heart rate, helps them, if they're going to be breastfeeding, it helps them establish breastfeeding faster, and just they can hear mommy's heartbeat and smell mommy, and things, it's just like they should be. Then getting into temperature control problems. Obviously, these little people don't come out looking like little fat roly-polies, most of them anyway. They come out looking like little rhesus monkeys. It's because they don't have a whole lot of body fat, because that gets put on in the last several weeks of the pregnancy. So these babies really can't control their temperature as well, so we have to do that for them, and that's another reason why we put them in an isolette, is so that they can use the calories that they're getting from any nutrition we're giving them to grow instead of having to burn it up to maintain their body temperature. Gastrointestinal problems. We've all had reflux or GERD in the adult version, where you lay down and all of a sudden you get this rush of acid in your back of your throat and kind of takes your breath. Babies can do that too. One, because of mechanical reasons, because we put a tube down their throat into their tummies to, one, help to relieve any air or mucus that's trapped in there from them swallowing, and to help them when we start to give them food. And this actually prevents the little muscle at the top of the stomach from closing down completely and allows some of that food to come back up and cause reflux. Fortunately, most of the time that is short-term, that once we get that tube out, everything's much better. Blood problems. Obviously, babies, if they have lost some blood volume from delivery for various and sundry reasons, a lot of them don't have a lot of blood volume on board anyway. And they can get anemia just from us drawing blood work and all to monitor that. And so they do sometimes require blood transfusions to replace that. Metabolic problems, the biggest thing are glucose and bilirubin. Glucose is manufactured in the liver, and the babies' livers are obviously a little more on the immature side, and so their risk is that they may not be able to make enough, or they've been under stress enough that they've used up all their supply. So we do support them with IV fluids of glucose and monitor them very closely during their course to make sure that they are able to take care of that on their own eventually. Bilirubin, that's where the babies look like they're have been suntanning when that's not the case. They get that nice little orange color, yellow-orange. Again, it's because of an immature liver. The earlier the baby, the more likely they will get that. Even term babies get bilirubin, can get jaundice because they're dealing with the same thing. They're just a little bit bigger and can sometimes get seen going more. Also, our preemie babies don't necessarily, if they're 30 to 35 weeks, they might not have their first bowel movement for a while, so they're absorbing the bilirubin from the stool that they haven't passed yet, and that helps to make them more yellow. Immune system problems, obviously we always check our preemies for infection because that is, as was stated earlier, one of the primary causes for premature births. We kind of went over sensory information and developmental care earlier, the other slide too. So I'm going to jump into feeding issues. If a mom is planning on breastfeeding, we actually encourage her to start pumping fairly soon after delivery as much as possible to start maximizing her milk supply and to give us any colostrum that she can possibly get, even just a few drops. It's liquid gold. It's actually the best medicine in the world for babies, and it's the only thing that mommy can give that we can't. We use it for oral care until we can start giving baby until mom gets enough supply built up so that we can start using it to actually supply feedings for. It is very important. It's the only thing that medicine cannot duplicate, and it actually helps prevent a lot of intestinal issues in premature babies or even term babies. So these mommies are going to be pumping a lot. We encourage them to pump at the bedside if they possibly can so that they can see baby because that helps stimulate it. If they've done kangaroo care, to pump immediately after. That makes a huge difference in their milk supply. But to be prepared to be doing this for a while depending on how young the baby is. Most preemies that are under 35 weeks aren't going to be gangbuster breastfeeders. It's going to take them a little bit to get going. Some babies don't have enough fat in their inside of their cheeks to create enough suction to hold onto that nipple and to actually help do some pulling to bring that milk down. And so they're going to take a lot of practice and will be kind of slow to get things started. May need some assistive devices to help get going, but we will work with you if that's your plan and do what we can to help you get to that point and to help baby get to that point. Kind of going along with this, I know several things come up, and one of the things is we see during this time is also about pacifiers. And we do offer pacifiers in the NICU to our little ones just because they're obviously not able to go and suck on the breast like they would, and sucking is actually a comfort measure for babies. So until your baby is actually able to start going to the breast regularly, we will use the pacifier to get them past that point and to help do some suck training too in that period. Sleeping patterns. Preemies sleep a lot. They will sleep 22 out of 24 hours a day to begin with, and that's pretty normal because they're not supposed to be here. They're supposed to be rocking in mommy. The older they get, they tend to be more awake at night because it's calmer and quieter. There's not a whole lot going on around. Tend to sleep very much more during the day. If there's a lot of visitors or there's been a lot of activity, moms sometimes don't understand why baby won't open their eyes and they seem to be like they're totally out. That's because they're trying to protect themselves. That's, again, one of those avoidance behaviors to protect their little brain. And they tend to eat more at night also. That's just part of being a preemie, and eventually they will get out of that pattern. Okay, long-term complications. Now, these are mostly what we see in the extremely premature baby, those born between 23 and 30 weeks. But some of these can happen depending on what's gone on with the pregnancy. Autism, there's been a huge outcry from autism people with complaining that vaccines cause autism. There's really no studies out there that prove that. Are some babies more prone to it? Yes, mostly genetics has a lot to do with it, but prematurity can also do with it. You know, obviously if the brain hasn't been able to develop like on that one slide showed, then the brain develops abnormally and autism would come into play with that. Cerebral palsy, this is related to a birth injury where the child or baby growing into a child may need braces on their legs. There's various and sundry different deficits that happen with cerebral palsy. Lung problems. Lots of these kiddos have asthma because of lung issues related to the ventilator. The main one is called bronchopulmonary dysplasia, otherwise known as BPD, and this is scar tissue that forms in the lungs because of ventilator or high oxygen use. Babies, fortunately, will outgrow it, usually by 4 to 6 years, but they will be basically asthmatic up to that time, maybe a little bit before that. Again, respiratory issues, they're more susceptible to the flu and the RSV, the respiratory syncytial virus that comes around, that in the adult could be just a common cold, but to a preemie could be life-threatening. Vision or hearing loss. Again, kind of the high O2 requirement in some babies can cause problems with the vision, and that's all related to the blood vessel development in the eyes. The higher the oxygen for a longer period of time, the more likely chance that those little vessels are going to develop abnormally. So we do vision checks on babies in the NICU if they're born before 34 weeks. Usually by 4 weeks of age, we will have a ophthalmologist come in and do a check, or have you go there as an outpatient if you're out before the 4 weeks is time. And so, unfortunately, some of our antibiotics that we give to cover babies, one of their potential problems is hearing loss, but we do very careful monitoring of those levels to try to prevent that from happening. Feeding and digestive problems, I referred earlier to gastric tubes babies, which would be a NG tube or a nasogastric tube that goes either down the nose, or an oral gastric, which goes down the mouth so that we can feed the baby. Or in extreme measures where the baby may have oral aversion, just does not want to do anything by mouth, they may need to have what's called a G-tube or gastric tube actually implanted into the abdomen, directly into the stomach. And that can be long-term or short-term, depending on. Necrotizing enterocolitis is an infection that's related to the bowel that can be potentially lethal. Breastfeeding, providing that breast milk is a huge protection against this. It coats and allows the bowel to heal. If it's severe enough, this does require surgery. Impaired cognitive skills. Obviously ADHD, some kids can get it mildly, some can have it a little more extreme. Mild mental deficits can be a problem. Dental problems, if your baby has to be, or not your baby, but if a baby has to be intubated for a long period of time, the tube can actually cause some erosion and disfiguration of the palate, of the gum, and even of the baby's teeth that hasn't erupted yet in the long term. So we try to decrease the amount of intubation period that we have, or since we don't do it a whole lot here, but in places like the University of Iowa, they would actually have the dental college come and create a palate plate to help prevent that. Chronic health issues, again, asthma, anemia, some kidney issues depending on if there's been problems with the medication, compromised immune system. Obviously, these kids are more susceptible to infections. And then behavioral and psychological problems mostly show up around school age. You may notice the child is more hyper, can develop oppositional disorder, and have difficulties with maintaining their focus on tasks. And again, while not all babies born premature do have complications, usually the earlier a baby is born, the more likely that the baby will be at risk to have complications. Some of these may be apparent right after birth, whereas others may take several weeks or even a few months to develop. Mercy's NICU, we take babies 30 to 32 weeks. Depending on what is going on with the baby, a 30 to 32-weeker may need to be transferred down to the University of Iowa for further care because they have more support down there. They have surgical support that is for the heart, the brain, or lungs, kidneys, you name it, they've got it down there. So they would be the go-to place for babies who really, really need further care. Fortunately, we don't transfer a lot of our babies, but when we do, we have a great place to send them to. We have a NICU nurse at every delivery, and this has actually helped to decrease the rate of NICU admissions because we can recognize if the baby's just in transition, stay and watch the baby for a little bit versus having to just whisk the baby away from mom and take the baby into the NICU and then maybe take baby back out later. We also have the largest private NICU suites in the area. They are beautiful. And obviously we have NICU lactation support. All of our lactation consultants are available to help out. And I'm a night shift person, so I'm the only night shift lactation consultant on. So I'm available for questions if need be and to help. And Dr. Roger Allen is Mercy's staff neonatologist. He is the most experienced neonatologist in this area, and he is phenomenal with parents and babies. So these are a few references that you can look up online. These are the ones that are approved and will give really, really good information. Other sites that you might look up to on the website might not be as reliable as these. So these would be the ones that we would really consider having you look at for further information. Okay, I'm going to give the mic back to Lynn now.
Well, thank you both for sharing your knowledge of premature babies. You obviously have a lot of experience working with those little ones. Now, to remind you, your questions can be submitted by hovering your mouse over the green bar at the top of the screen. Okay, we'll begin with our first question. First question is, I would like family members with me at the birth of my baby. Will they be able to visit if I deliver prematurely? Who would like to take this question?
Okay, I'll go ahead and take that one. Yes, family are welcome to visit the baby in the NICU. We just encourage that if the baby is on minimal stim protocol, or very sick, that you limit that to just 2 visitors besides mom and dad in the room for just brief moments. And again, we would ask that, respect the baby needs for that. And then as the baby gets better, then mom is able to move in with baby, and obviously then as baby starts to improve more, then there can be more visitation for longer periods of time where grandmas and grandpas and aunts and uncles can hold.
Okay, thank you, Brenda. Another question, my sister's babies were both delivered early. Will I be more at risk for premature delivery also? think Linda's going to take this question.
Well, the answer is not necessarily. A lot of it depends on why your sister delivered her babies early. So as we talked about before, there are risk factors that are things that are inherent or you're born with that you can't help. And then there's risk factors that you can control, such as smoking, using alcohol, having a healthy diet. So if your sister's deliveries were due to choices that she made in her pregnancy that could be controlled and you choose not to make those choices, then you would not be at risk for those reasons. If, however, she had an early delivery because she had a different shape to her uterus, there's a possibility that you inherited the same, and that might be something that could happen in your situation as well. But as we talked about before, just because you have a different shape to your uterus doesn't necessarily mean that you would deliver prematurely. So the answer is yes and no. The things that you can control are always your choices, and then anything that might be inherited or congenital could be inherited for you as well.
All right, thanks, Linda. Next question, if my baby would need to be transferred to the U, would I have to stay in Cedar Rapids or could I go with him? I think Brenda's going to take this question.
Now, if your baby would be transferred, even if you've just been shortly delivered, our doctors are great. If we call your OB and tell them what's going on, they will call down to the U and actually transfer your care to one of the OBs down at the U to continue your care so that, yes, you would be able to go down and be with your baby.
I also want to point out, if you think of a question after the webinar ends, our Linda and Brenda could both be contacted by the email address on the, or go and get more information from the website, or by giving a call to the number on the screen, which is 319-363-BABY or 2229. Another question, I don't want my baby to have a pacifier, but you said premature babies are often given one in the hospital. So what is your advice once the baby's home? And Brenda's going to take this question also.
Again, once your baby is able to go to the breast more frequently, we will start to limit the amount of pacifier use. But until that time, we would use the pacifier during like our NG feedings to stimulate the baby to get the idea that, oh, when I suck, my tummy gets full. So we use it kind of as a suck training method, or if we have to draw blood on the baby, we use it actually as a pain control and give them a little bit of mommy's milk or some sucrose if they're formula feeding to help decrease their pain for those procedures. So that would be a temporary thing then.
We don't have a question, but we'll, while we're waiting to see if there are any more questions before the end, I want to tell you about our next webinar is Hospice and Palliative Care with Dr. Amanda Summerfeld. She's the Hospice of Mercy Medical Center's director. It will be broadcast live on Thursday, November 7th at noon to 1, and she will take your questions live after the discussion. Now, a tape of this program will be available at www.mercycare.org/live within the next day or so. And you can always check this website for information about future webinars and listen to past webinars. If you're interested in future Mercy webinars or other events, you may also sign up for Mercy's electronic newsletter at mercycare.org/e-news. Okay, I believe we have covered all the questions submitted to us, but again, if you have additional questions or concerns, you can be reached at the number on your screen, Brenda and Linda can be reached at the number on your screen, 319-363-BABY. Oh, we have one question come in here. Hold on. If I were to tour at Mercy, are we allowed to go into the NICU to see the rooms as well? Or how do I go about touring? Oh, that's a very good question. Who's going to take the question? Brenda will?
Yes. Michelle Altmaier is our tour person, and she does an excellent job of giving our tours. So you could contact her or go onto the web page, I believe, to schedule a tour. And yes, she will, as long as we have a room available to show you, then yeah, come in and you can actually talk to a NICU nurse and kind of get an idea of what some of the equipment is in the room and how it's all set up and what, you know, would go on at that point in time. But yeah, she covers pretty much everything when she does the tours. So
I'm sure that's very reassuring to know what the area looks like during the tours, and hopefully not needing it. All right, I believe that does it for our questions, and I wanted to thank you all for joining us today. Thank you.